And welcome to the Allen Temple Baptist Church Health Education Ministry webinar, Science and the Future of COVID, the Pandemic Science and the Pandemic Impact in Communities of Color. We welcome you and thank you for coming this morning. We're going to ask our Deacon Michael Johnson for invocation.
Good morning, brothers and sisters. Thank you so much. As we begin this invocation real quickly and briefly, I would start this morning with scripture. It's coming from 3 John 1 and verse 2. It's from the Amplified. Beloved, I pray that in every way you may succeed and prosper and be in good health physically, just as I know your soul prospers spiritually. And Psalms 103:2-3 says, bless the Lord, O my soul, and forget not all his benefits, who forgives all your iniquities, who heals all your diseases. Let us pray. God, our Father, we thank you for this morning. We thank you for this opportunity. We thank you for the purpose. We thank you for the plan. We thank you for the participation and the presentation from those that you have set aside, Dr. Swartzberg and Dr. Kim Rhodes. I ask, oh God, that you would just sanctify them as they impart all of the important information we need to know more about this pandemic that we are confronted with. We pray for the two of them that you have prepared them, you have purposed them, and you have skilled them, oh God, and they have perfected these skills. And so we ask, oh God, that you would use them to your glory, that all of us will be informed and enlightened and empowered to know more about this pandemic, know about how our purpose in making sure that we are safe and how that information that we can pass on to others so that we may remain healthy and that you will be able to heal us and heal this land. We ask it all, Lord, in the name of Jesus the Christ. We lift up our pastor as well. We thank you for her steadfastness, her wisdom, her leadership. Guide her and direct her as we go forward in this day and days ahead. In Jesus' name we pray. Amen and thank God.
Amen and thank God. We want to thank Deacon Michael Johnson. He is a member of our church, Allen Temple Baptist Church in Oakland, since 1981. And we want to thank him for that prayer. He's an ordained deacon and was ordained in 1985 and currently serving as the chaplain of the ministry. He's worked in various places in mental health since 1995, and he served as a facilitator for a behavioral modification program for the Alameda County Library Reading for Life program from 1995 to 2000. Currently, he's serving as one of our Allen Temple Health and Social Service Ministry as a facilitator in the domestic violence anger management programs. We thank him for that invocation and prayer. And now we're going to hear from our Dr. Reverend Jacqueline Thompson, Senior Pastor of Allen Temple Baptist Church, Oakland, California. Pastor.
Good morning, everyone. I pray that this presentation finds you all safe and well. I am so happy that you all are joining us today. So let me take this opportunity to welcome each of you who are joining us and ask you to take a moment and share this webinar. Text someone, call someone, email someone, let them know that we are having this webinar, and we have two incredible experts that are going to be giving us up-to-date information about the impact of COVID-19, particularly in communities of color. If you are like me, you remember that initially when all of this started, March of 2020, they told us it was going to be 2 weeks. And here we are now, almost 2 years later, still having these conversations, still trying to figure out how to stay safe. And so with nearly 6 million people who have passed away from COVID-19 worldwide, and near a million of those in the United States, it is so important for us to continue to have this conversation because we know that there's been adverse impact in communities of color. So let me extend my heartfelt thanks to Dr. John Swartzberg and to Dr. Kim Rhodes, who are here to educate us. Prepare your questions. All of those things you've been hearing that have been circulating in your families and amongst your friends group, we want to make sure we have accurate information from people who are on the front lines. And let me also thank them, because it's been from counsel like theirs that have guided us in the decision-making process that we have had for the reopening of our church. And I am proud to be able to say we have been worshiping in person in a limited capacity since July with not one incidence of COVID on our campus. And it's in part because we depend on science such as this. So please avail yourselves. And thank you, Health Education Ministry. Thanks to our leaders, Deacon Harold Goodman, Sister Nubia King, all of you who are working with this ministry today to make sure that this is a wonderful presentation and a wonderful way to keep us safe as we move forward in what they're calling an endemic, but I'll just say we'll see. So during all that time, you should have had an opportunity to tell somebody to join us, and avail yourself to this information and share it. God bless you. And thank you to our moderator for today, Sister Rika, for that gracious handoff. I'm handing it back to you. Have a great session.
Thank you again. That was our Dr. Reverend Jacqueline Thompson, Senior Pastor of Allen Temple Baptist Church. And again, my name is Ms. Rika White-Soso, Sister Rika White-Soso. I'm a licensed clinical social worker here in Oakland, California. I serve in private practice and I'm a member of the Health and Education Ministry. I'm so happy to be here this morning to help moderate this particular very, very important topic, science and the future of COVID, the pandemic's impact on communities of color. And so we have some experts here with us. I'm going to introduce our Dr. John Swartzberg. He's a clinical professor, Emeritus, infectious disease and vaccinology. He's working at the UC Berkeley School of Public Health. He chairs the editorial board chair. He's the directed many coverages of the University Health Wellness publications since 2001. He is also a past director of the UC Berkeley UCSF Joint Medical Program. Swartzberg is board certified in internal medicine and infectious diseases. Before joining UC Berkeley faculty full-time in 2001, he spent 25 years in clinical practice. He is also the hospital epidemiologist and chair of the chair of the Infectious Control Committee at the Alta Bates Medical Center in Berkeley. He also teaches and taught 2 semesters of graduate coursework in infectious diseases, as well as a seminar on healthcare associated infections at UC Berkeley. He has collaborated with the late Sheldon Margin, a pioneer in nutritional sciences and co-founder of the Wellness Letter, on the highly successful Wellness Self-Care Handbook in 1998 and the Complete Home Wellness Handbook in 2001. He comes to us with so many accolades and everything. We are so happy to have him come this morning. Dr. John Swartzberg.
Thank you very much for that introduction. I'm very honored to be asked to speak with you today, and I'm particularly thrilled to be speaking with my friend, colleague, and former student, Kim Rhodes, Dr. Rhodes. So it's a real thrill for me. I'm going to share my slides with you. I'm getting there, excuse me. Okay. So for the next roughly 30 minutes, I'd like to speak to you about these topics: the state of the pandemic, and then it's all about Omicron, at least right now, and then go back to the state of the pandemic, then talk a little bit about vaccine effectiveness against Omicron, raising the question then about a 4th booster, and then talk about how have we done in these 2 years, we meaning the United States, and where do we go from here? So that's my agenda. And I think I should take, as I said, about 30 minutes and leave some time for questions. So first of all, this is the state of the pandemic. Let me just run through the history with you. It's, as was mentioned, it's just been 2 years, but frankly, for a lot of us, certainly including me, a lot of it feels like a blur. We began almost exactly 2 years ago with the recognition of this, what we're calling the ancestral strain of this virus that first caused disease probably in late November in China and first reached the United States early in January. In the summer of 2020, we had our first surge, and at that time it seemed pretty formidable. And this was a new variant of the ancestral strain we called D614G. It never got a Greek letter. And then we came out of that and thought things were going to be okay. We never quite reached the baseline to where we were previously, but not too far from it. And then we had that horrific late 2019, early 2021, late 2020, early 2021 surge that I think all of us remember of this of December and January. And this represented the zenith, which occurred about the third week of January of 2021, almost a year ago. And then just like now, things dramatically got better in February and March. We had a little blip in April from a new variant called Alpha that had caused a lot of the disease in the United Kingdom in December and January, in the preceding December and January. And then after Alpha, we reached really the nadir of cases going back to the beginning of the pandemic. I remember in early June, I was, along with, I think, just about everybody, thinking we were at the end game of this pandemic. But alas, that wasn't the case. And by early July, we started to see cases of Delta building up. Now, Delta had been in India, recognized in India since the fall of 2020, but it didn't really do much in India until the spring of 2021, when it exploded in India and caused an enormous number of cases and tragically an enormous number of deaths. And we suffered considerably from Delta during that summer, but things got better and we started to loosen up things by the end of September, early October, when cases were about halfway down from the Delta surge. But building right on top of the Delta surge was Omicron. And our first cases here in the United States in Omicron were in early December. And right now, as you can see from this graph where we are just about at a level of about halfway down from the Delta surge last summer. And we're just about at when the Omicron surge began. So that's the background I wanted to leave you with. But continuing to talk about the state of the pandemic, this is one of the tragic things that we've seen. And I think we're all aware of this. The average life expectancy dropped by nearly 2 years. And this is the sharpest decrease in the United States in life expectancy since World War II. And of course, and I know Dr. Rhodes is going to be talking to you about this, but the tragedy and people losing their lives was not uniform throughout the United States. Particularly people of color here in the United States suffered and continue to suffer much more than non-communities of color here in the US. One of the real tragedies tucked into this tragedy. Roughly in 1 year, we've erased close to 2 decades of progress on longevity, as you can see from this graph. So this looks at the variants that we've been dealing with since November of 2021. As you recall from what I was showing you earlier, in November of 2021, essentially all the cases were registered here in orange, and that represented the Delta surge. But then we started to see by early December that there was a new variant in town, and this was Omicron. And Omicron is reflected here in both the light and the dark purple. And you see that Omicron has completely replaced, really almost essentially 100% of all the isolates here in the United States now are Omicron. So this has become really a pandemic now of Omicron. This looks at the ancestral or the SARS-CoV-2 tree, if you will, of variants. And it really reviews what I was talking with you about. We had the ancestral strain that was here that caused a lot of disease, D614G, which I had mentioned in the summer of 2020, that caused a moderate amount of disease, and then considerable disease in the winter of 2020-2021. And then in the summer, we suffered greatly from Delta. We had preceding that a little bit of Alpha, but Delta caused an enormous amount of disease. And then we have this new branch of Omicron. And I'll talk more about 3 lineages of Omicron. There's BA1, BA2, and BA3. BA3 has never amounted to too much. BA1 has been the predominant and continues to be the predominant one here in the US. But BA2 is starting to make some headway in the US. And I'm going to go back and just show you that the light purple here, or pink, represents BA2. So we're seeing BA2 growing here in the United States. Not as rapidly as other places in the world. Denmark, almost all the isolates there are BA2. In India, almost all the isolates there are BA2. In South America, in some of the communities, it's the majority isolate. So BA2 is outcompeting BA1, which we're dealing with primarily here. It's competing BA1 in several parts of the world. I'll come back again to talk more about that. So this is really what we've seen about Omicron. And this is a time scale that I put together where we first saw on November 21st, 2021, that a new variant was reported to the WHO. It had actually first been detected in Botswana on November 11th, and on November 14th, it was detected in South Africa. Now, I'm emphasizing the word detected because that doesn't mean that that's where Omicron began. It's just where it was first identified. And part of this has to do with the really superb, actually superior detection methods that South Africa has. On November 26th, the WHO named BA 1.1.529, which was really a mouthful, named it Omicron, and classified it as a variant of concern, VOC. On November 30th, 4 days later, the United States designated Omicron as a variant of concern. And on December 1st, the first confirmed case of Omicron was identified. So the numbers of cases of Omicron we're having now are roughly at the level of the number of cases we had on December 15th, 16th, and 17th. So just about 2 months ago. So 3 big questions about Omicron. Its transmissibility, how well it can evade the immunity we get from vaccines or previous infection, and how sick does it make us? What is its virulence? Let's address each of those. In terms of transmissibility, I think there is clearly a scientific consensus now that it is more transmissible than any of the previous variants by probably a factor of 1.5 times. Some people think up to twice as transmissible as Delta, which was the most transmissible prior to Omicron. So the virus is learning how to transmit better in human beings as manifest by Omicron. When we look at BA2, that variant of Omicron, it appears to be more transmissible than BA1 by a little bit, but that data is soft and subject to change. If we look at immune evasion, I wrote this put this slide together on Wednesday, and Wednesday night, a new paper came out, not peer-reviewed, but nevertheless done by a good group, and it suggests that BA2 has more immune evasion than BA1. And that's disturbing if it's true, because we know that Omicron, BA1, has the ability to evade our immunity, either from infection or vaccine, greater than any previous variant, including Delta. So that's of concern. It can't completely evade it, but it does evade it to some extent. And then the third question about how sick does it make us, its virulence. I also put no 3 days ago, but that same group also suggested that there's some evidence that it may make at least some people sicker. So again, the data on immune evasion and virulence for BA2 is really preliminary, but we need to follow the story. So going back to the state of the pandemic, let's look at what happened in South Africa. This was South Africa's winter, this big surge that they went through, and this was from Delta. And it was the most serious surge that South Africa had experienced. Things got a lot better in September and October, and it looked like this was the lowest level of cases that South Africa had had since really the beginning of the pandemic for them. And then the Omicron surge began in early November, and we saw what happened. And you'll note that the descent of the number of cases really pretty much looks just like the ascent, except that here's where South Africa is now, and note that it looks like it's plateauing, and it's plateauing at a level of cases that's higher than after any of their other surges. And this is something that's very disconcerting, and we're keeping a close eye on. That is, South Africa has not been able to drive the numbers down all the way like it did after Delta. And this looks at the UK, which was the second large country that experienced Omicron. And we saw here that the Omicron pandemic began roughly at the same time that we experienced, actually a couple weeks earlier, and we saw what happened with that. And again, the rapid descent, but we're seeing a similar pattern to what we saw with what we're seeing in South Africa, where it looks like, at least now, that in the UK, the descent seems to be plateauing at a level that's higher than at any time they've had. So this is of concern and something we're watching very closely. And here's the United States and our experience with Omicron. You'll note that we never got down to a good baseline after Delta, and so the Omicron built on a higher baseline than we'd previously experienced. This represented the summer Delta surge that we had, and this represented last winter's, the winter of 2020, 2021. And the worst surge we had had prior to Omicron. And this is the number of cases of Omicron reaching a little over 800,000 cases per day. And you'll note that the United States has had a really wonderful descent in cases paralleling what we saw with the ascent. And this is roughly where we are. This is from 3 days ago. And you'll note if you draw a parallel line over here, we're just about where we were in the middle of December, as I had mentioned. And we are just about halfway down from the Delta surge of the summer and fall of last year. So whether the United States is going to show the same pattern as we've seen with South Africa and the United Kingdom, where we're going to sort of stall out at a higher level or not, remains to be seen. But it does make one pause in terms of how much we want to relax things right now when we're not even back to where we were when Omicron took off. And if we look at hospitalizations here in the United States, we'll see that we're roughly about where we were during the Delta surge of the summer in terms of the number of hospitalizations. Still quite a few, but still but remaining as disturbing number. And I just wanted to point out that when we look at hospitalizations, I'm going to come back to this theme on 2 or 3 more occasions, that if we look at the number of hospitalizations, this is 50 to 64 years of age. These are per 100,000. We see that in the US, almost everybody who's hospitalized are the unvaccinated. And if we look down here, the number of hospitalizations, if you're vaccinated but not boosted, that is, you haven't received your 3rd jab of an mRNA vaccine, for example, you can see that, that there's not a great difference, but there is a significant difference in terms of the number of hospitalizations for people who are vaccinated but not boosted compared to people who are boosted. And that's, I think, a very important thing we want to keep our attention to. And if we look at the number of deaths here in the United States, we see that they've peaked probably about a week ago, maybe a little less, and that they do clearly appear to be coming down, which is what we would expect given the case counts having dropped. But you'll also note that the number of deaths occurring daily in the United States are higher than the number of deaths we were having at the peak of Delta. And that's of great concern. And this just looks at, I pulled some data from Switzerland to show you. This was from about a month ago, actually exactly a month ago, where it again showed that deaths in Switzerland, the unvaccinated compared to the fully vaccinated without a booster compared to those with a booster. What a dramatic difference between these, but also a significant difference between being vaccinated but not boosted compared to being boosted. So one of the questions that comes up is, and I mentioned this earlier with immune evasion, is how effective are our vaccines against Omicron? And if we ask the question on this side of the graph, how effective are the vaccines in preventing infection? With 2 jabs of an mRNA vaccine, they're only about 25% protective. With 3 jabs, about 50% protective against getting infected. What I mean about getting infected is that infection could be symptomatic with a mild symptoms to moderate symptoms, or it could be what we call asymptomatic infection. That means you're infected, but you don't even know it because you're not even sick. What we're very much concerned about is our hospitalizations and deaths. So let's look at those. With hospitalizations, with 2 jabs of an mRNA vaccine, you're at about 58% protection, not quite 60% protection against getting hospitalized. If you've had 3, you're at 90%. So 90% reduction in the risk of getting hospitalized if you've had 3 jabs. And deaths, the numbers are pretty much the same, about 60% versus, in this case, 95%. So dramatic difference. Bottom line to these slides that I'm showing you about 2 jabs versus 3 jabs against Omicron, it's completely clear that you get so much more protection with the 3rd jab. And this is just some data from a week ago from the Centers for Disease Control on people ages 50 to 64 with the Omicron pandemic. Almost all of these cases, not all, but almost all of them were Omicron, a few were Delta. We saw that the vaccine effectiveness against preventing hospitalizations is in the orange line. In the dark blue line, it represents those who are fully vaccinated without an additional booster. And these were people in the lighter blue line that were fully vaccinated with a booster. Roughly 45 times greater risk of being hospitalized if you're not vaccinated than if you are. And this is in people ages 65 years or over. Again, during the same period, the same color coding. And the risks if you're 65 or over of being hospitalized are 51 times higher if you're not vaccinated compared to if you are vaccinated. I'm clearly battering you with this theme of how critical it is to be immunized and how critical it is to be optimally immunized. And yet, tragically, we even with this data, we don't see people availing themselves to the extent that they should. Even older people in our society are not getting their third jab. That is, they're not up to date with vaccination. So this was a study done by the Kaiser Family Foundation about 3 weeks ago. Will you get a booster dose? And that you can read these as I can. As soon as I can, 40% said that. I'm going to wait and see how the boosters are working. 16% said that. Only if required for work, school, or other activities. 22% said that. And 20% of the people said who had gotten vaccinated, but would they get a booster dose? Almost 20% said they wouldn't get a booster dose. So these aren't people who are opposed to vaccination. So if we look at the booster dose and comparing how the United States has done, this slide of the graph looks at the share of population that's fully vaccinated. And these are other large high-income countries compared to the United States. We're following woefully below other large high-income countries in terms of fully vaccinated, which means 2 jabs. If we look at those people who had 3 jabs, that means they're up to date. The United States exceeds all of the other high-income countries with the exception of Japan. Excuse me, the United States is lower than all the other high-income countries with the exception of Japan. And this relates directly to cumulative deaths during the Omicron wave. Here are the other high-income countries that we compared. I've compared the United States to, and here's the United States in terms of cumulative number of deaths during the Omicron wave. So this is not from the beginning of the pandemic, it's from December 1st. Look at the difference between how the United States has done compared to these other high-income countries. And this correlates directly with how many people have been vaccinated, fully vaccinated, and how many people have been boosted. So this raises the question then, do we need a 4th booster? And this is very preliminary data from Israel that now recommends a 4th booster for people 60 and over, and will give a booster to anybody where the vaccine is to whom the vaccine is approved for. And this looks at increased protection against severe disease, so hospitalization and death. And you can see that there was a significant improvement, but it was a very short-term study that was just 12 days after vaccination. So we need a lot more data to confirm this. So here's some data that we do have here from the United States about our immunity waning to the booster dose or to the two jab regimen, that is being fully vaccinated but not boosted, or being up to date, that is with boosting. And this was published on February 11th, so 8 days ago, in the weekly Morbidity and Mortality Weekly Report. And they looked at the 2-dose and 3-dose effectiveness of the mRNA vaccines. And they looked at 2 groups of people who either went to the emergency room or urgent care center because they felt they needed to be seen, and people who were hospitalized. So those were the 2 groups. And it was during the Delta period and Omicron period. So here's the bottom line to that study. During the Omicron predominant period, so the period we're just leaving now, starting to leave now, 2 months after people got their 3rd jab, the number of emergency department and urgent care visits, you received about 87% protection with that 3rd jab. And you received 91% protection against getting hospitalized. This was compared to people who had 2 jabs and compared to people who had no jabs. 4th month after the 3rd dose, the number had dropped from 87% for the emergency department urgent care visits to 66%. And hospitalizations had dropped from 91% to 78%. So clearly a waning of immunity after the 3rd jab, after 4 months. And this, of course, raises the question of, should we get a 4th jab, and who should get it? this looks very busy, and it actually is just a repetition of what I've shown you before in terms of how the United States has done. If we look down here, the United States is the worst amongst, this looks at Spain, Denmark, Ireland, France, Germany, and the United Kingdom in terms of the share of the population fully vaccinated. And this looks at those people that were boosted. The United States is way below again, and how this correlates directly with new weekly hospitalizations, how the United States is at the top, and confirmed deaths per 1 million people. All of these are per 1 million, and the United States is at the top of that. Again, showing the value of being up to date, that is being boosted, but our immunity is starting to wane after about 4 months. And this looks at, this is from the United Kingdom, and they looked at what the United States, if it had halved its, would have halved its COVID hospitalization had it matched the breadth and depth of vaccine coverage in leading European countries. So this looks at July 2021, so it took us through our Delta surge and then the Omicron surge. And it compares in the blue here, hospitalizations if the United States had matched Denmark's coverage. And this is how many hospitalizations we actually have had. We think that we're approaching, as was mentioned, 1 million deaths here in the United States. We'll be at probably 1 million sometime by the end of March, maybe a little bit earlier. And we think that in the last several months, we could have averted almost 100,000 of those deaths had we done better with our vaccines. So another way to look at this is that the United States represents 4% of the world's population. And in terms of cumulative deaths since the beginning of the pandemic, the United States comes in second worst in the world in terms of cumulative deaths per 1 million. So this is per 1 million, so it's a rate, not absolute numbers. Brazil is the only country that's done worse than the United States. And it's interesting to note the similarity of political leaders in Brazil and the United States during the previous administration. So going back over here, we represent 4% of the world's population. We represent 21% of the world's number of cases, and we represent 15% of the world's deaths. So that brings us to the question is, how has the United States done? And this is an article that was published about 3 weeks ago in The Lancet that attempted to answer that question. And it looked at factors that about infection, fatality rates, and preparedness in 177 countries from January 1st, 2020 through September 30th, 2021. So it really included last year's data. And these were the number of cases per 1,000. And of the 177 countries, the United States was at the top with 554 cases. But I think what was most interesting to observe or to learn from this article were two things. One is that moving every country up to the 70th percentile in trust in government, which is roughly where Denmark sits, this would have prevented 13% of the global infections. And if you moved every country, those 177 countries, up to the 75th percentile of trust in their fellow citizens, which would be roughly South Korea's level, we would have prevented 40% of global infections. So this informs us, I think, a great deal about how communities are necessary to tackle this pandemic and how it's necessary for us to have strong communities within our society. So where do we go from here? This is speculative, obviously. No one really knows where we're going to go from here. Omicron has been incredibly humbling for all of us. But I'd like to give you what I think are the worst and best case scenarios. I'd like to bring up this topic of endemicity and discuss this in a little more detail, and then briefly talk to you about should we be optimistic going forward. So first of all, in terms of best and worst case scenarios, the worst case scenario, I think, would be that within the next very few months, a new variant emerges that has increased transmissibility, is able, even better than Omicron, to evade the immunity we get from vaccines or previous infection, and that it makes us sicker than even Delta did. The best case scenario is that there are no more variants at all, and that we have more diagnostics and therapeutics available to our public. And likely with most things in life, we're going to wind up somewhere between these two poles. I think it's highly unlikely that we won't see another variant, but we have a good shot at these new variants perhaps not possessing all three qualities of increased transmissibility, increased immune evasion, and increased virulence. So I suspect we're going to be somewhere in between here. And one of the things that I'd like to reflect on in terms of what may help us in this scale, if we will, is what was just presented on Thursday from the governor. And I do want to reflect on this Smarter California. But let me hold on that just for a moment and address this thing about endemicity. We're hearing so much in the news and so many people talking about the United States is now going into an endemic state. Whereas quite a few of my colleagues and I wonder whether we're talking about an endemic delusion. Endemic really means that we have a relatively steady number of cases in society over time. So instead of dealing with this roller coaster we've been on of these surges and then quiet and then surges and quiet, that the pandemic is really now becoming endemic in the sense that it's just a steady state of cases. But one thing to reflect on endemic, it doesn't say anything about the number of cases. It could be a steady state of cases at a very high level, or it could be what we would wish for would be a steady state of cases, an endemic disease at a low level. So we have no idea where we'll stand, even if we do reach a state of relative equilibrium in the number of cases. This is opposed to an epidemic, which is a surge in the number of cases beyond what is expected. And a pandemic, of course, would be an epidemic occurring on a worldwide basis. So this is just what I showed you at the beginning of our talk on where we are. And if you look at this now, keeping this in mind over here, I don't think any of us would say at this point we've reached endemicity. And people who talk about that we're going to be endemic or we're in an endemic state are either deluding themselves, because we're not certainly at this point, or they're being hopeful that that's what's going to happen. Just like we were hopeful after the winter of 2020-21, when we saw this major dip in cases. And I remember how hopeful I was here, only to be greeted within really about a month or so with Delta. And the similar phenomena happened here after the summer surge of 2020, where we never reached a baseline again, and we just built on it. So what about optimism? SARS-CoV-2 is formidable. I think we all will acknowledge that. This is the worst pandemic that the world has experienced in over 100 years, since the great pandemic of 1918 and 1919 with influenza, and that SARS continues to be able to outrace what we've been doing up until now. But on the other side of the scale, which I think is going to weigh differently soon, is we have better and more available diagnostics than we've ever had. We have better and more available therapeutics than we have ever had. and we have more people immune, either from previously being infected or preferably from being vaccinated than we have ever had. And so these three things will stand us in much better stead if we can make them all if we can optimize all of them. So in terms of better and more available diagnostics, well, we received in the mail, my wife and I, 2 diagnostic kits, rapid tests from the government this previous Monday. We have been woefully behind for the entire pandemic from the very beginning with having adequate diagnostics available to us. And while we have now monoclonal antibodies that do work against Omicron, and we also have therapeutics that work against Omicron, I'm particularly referring to the oral drug Paxlovid, although we have another one that has an emergency use authorization called molnupiravir that doesn't work as well. They're not very available. It's very hard to get these. We don't have nearly enough of these. And while we have more people immune, we still don't understand how long this immunity will last. Is vaccine-induced immunity better than, the same as, or worse than infection-induced immunity? There still remains debate about this, although I think there's clearly a consensus that people who have been vaccinated and who have had COVID have the best immunity. And certainly in my mind, vaccination is far preferable to getting COVID because you have no idea what your outcome may be, not only in terms of hospitalization and death, but also, of course, in terms of long-term damage, for example, long COVID. So thank you very much, and I will end here, and I'm happy to take questions.
Thank you so much, Doctor. I'm going to need assistance with starting up my camera. Thank you so much.
You're welcome. I'm trying to get rid of this screen, and I'm having trouble doing it.
Just a moment. Everyone, thank you so much again for being with us on this Saturday, hearing again about the science and future of COVID, the pandemic impact in communities of color. I'm going to need some assistance coming back on screen. I can't start my. Thank you. All right. Good morning again. That was so informative. We have, oh my goodness, so much information there. From March 2020 to today, this pandemic has definitely hit us all. I heard you say, Doctor, it is critical to be vaccinated, but even what would be better is to be optimally vaccinated. I heard that message. Let's see if we have some questions. Let's see. I'm going to go into chat here. Let's see. Okay, from an anonymous attendee, do you think we will have to have an annual vaccine such as the flu shot?
Yeah, that's such an important question. Given how our immunity appears to wane from either infection or from vaccine, it does. I think it's unlikely with the vaccines that we currently have that we will have a vaccine that will last us years. You know, if you get the measles vaccine and you get those 3 doses, you're just never going to get measles again the rest of your life, almost never. But that doesn't appear to be the case with this coronavirus, and just like it isn't with influenza. So I do think that it's likely we are going to need regular vaccination. Now, there's a tremendous amount of work being done on developing a vaccine against both influenza and also against COVID that will cover all the variants. We call this a pan-COVID vaccine or a pan-coronavirus vaccine. And if we can develop that, then we may be talking about a much longer immunity. So fingers crossed.
All right. We have another question. Any updated data on COVID vaccinations for our children, among the children, the youth?
Yeah, a couple things to say about that. We have in the the last time I checked, about 62% of children in the United States between the ages of 12 and 18 have received 2 jabs. I'm sorry that number isn't higher. If you look at children between 5 and 11, the number's around 30% have received both jabs. That means 70% of our children between 5 and 11 are not protected. And that's very disconcerting. And then, of course, I think, as everybody knows, we do not currently have a vaccine for children between the ages of 6 months and 5. We were hoping to have it by early spring, and I think that's clearly going to be delayed. I think the earliest we could hope to have something will probably be April, and that may be optimistic.
Thank you. We have quite a few questions. Let's see. We have another question. I'm going to start saying the names of persons, if that's okay. If you don't want your name said, please let us know that. But we have a question from Martha Taylor. It says, I fall within the age category for an additional booster. How and where can I get it?
Well, everybody from the age of 16 on is in the age category to get it. I think the question is an additional booster. Got it. A 4th jab with the mRNA. Got it. There's the criteria currently for getting a 4th jab is if you're immunocompromised at any age. This is likely going to change given the data I showed about the declining immunity. If you are in the immunocompromised category, you can get the 4th jab anywhere. You could, for example, go on to CVS and just make an appointment, and you have to check a box saying you're immunocompromised. If you're not immunocompromised, some of the pharmacies will not give you a 4th jab. So you'll have to look elsewhere for the clinics that are offering vaccines if you choose to get vaccinated. This is a really tough question here. From a public health standpoint, we don't have the data at this point to suggest that you need a 4th jab. And frankly, with the number of Omicron cases dramatically declining, we're going into a much more quiet period. For how long, of course, no one knows, where the risks to us is going to be much less. So it becomes more of an individual decision about your risk tolerance, whether you want to do something that is get a 4th jab where we don't have a lot of data to support that it's a good idea. So one of the situations that I've talked about with a lot of people is that some people who are going to have to be in a situation where they're at increased risk of getting infected. Let's say they have a sick family member across the country, they have to fly, and they may need to go to a wedding or tragically a memorial service where the risks may be much greater, but they just feel they have to do this. And that may mean that they might choose to get that 4th jab, even though they're not immunocompromised. If somebody's got diabetes or obesity, chronic lung or heart problems, these put you at increased risk of having a bad outcome. And so you might decide, even though there's not enough data, that you'll go ahead and do that. But you're really doing something on your own right at that point.
Thank you. Thank you. We have another question from Lonnie Wilson. What are the chances that a variant will arise that is able to evade vaccine immunity?
I don't know. It's a great question, and no one knows the answer to that. I think it is, we've seen this happen with Omicron, and given that we have been completely unsuccessful at getting the world vaccinated. Every person who's not vaccinated is really a viral production factory, potentially. And when you're producing billions of viral particles, the virus is going to make mistakes. And some of those mistakes, a very few of them, will be advantageous to the virus. And that's where variants come from. So as long as we have a world where the majority of people are not even the majority, where so many people are not vaccinated, this virus has the potential to develop variants. And we've seen nothing to suggest that it's going to stop after Omicron. So I think there's a high degree of probability that we're going to have a variant. Now, will that variant be able to escape our immunity that we have? Well, probably, at least to some extent, like Omicron did, because that's how it's going to be able to spread. So I think that, I had those two poles on that with the arrows, and I think there's a likelihood we're going to be confronted with a new variant. I doubt that it's going to be the worst case variant, but I think there's a good likelihood we're going to face new variants. Now, the good news is that we know how to produce vaccines against new variants, but it takes a few months, and that means that a lot of people will suffer and die in that interim.
All right, we have another question. And this question is from one of our Facebook viewers. Caller Keener is asking, is there more information on Pfizer COVID pill?
That's the Paxlovid. And yes, there was a paper that was just published in the New England Journal within the last couple of weeks. The data really looks good. In non-vaccinated people who got infected, it reduced their risk of hospitalization and death 90% compared to non-vaccinated people who did not take the pill. That's an incredible number. It just is outstanding. Not as good as penicillin for a strep throat, which is about 99%. But 90% is awfully good. I think the number was 89%. It's awfully good. Paxlovid, but there are a few things I'd like to say about this. It appears to be quite safe, well tolerated. You have to take it for 5 days. It's actually 2 pills for 5 days. It's a combination of 2 different drugs, actually. But one of the drugs that's combined with interferes with how our bodies metabolize or break up many medicines that we might be taking. So, for example, if you're taking a statin, like Lipitor, and you have to take Paxlovid, you're going to have to stop that statin beforehand, because otherwise you could have build up toxic levels of it. And there are a lot of other drugs that would fall into that category. So the first caveat about this drug is that it's very important that your doctor is informed and informs you, and that your pharmacist informs you knows what drugs you're taking to modify the dosage of those drugs while you're taking Paxlovid. So that's the first thing. The second thing is that the trials all looked at people who got the drug within the first 5 days. So if you wake up and you've got a sore throat and you think, maybe could I have COVID? You're going to have to get tested. The test has to be positive. You're going to have to contact your doctor, and your doctor is going to have to be knowledgeable about this and call the prescription in to the pharmacy. And you're going to have somebody go to the pharmacy and get it for you. And that has to be done preferably within the first 72 hours and certainly within the first 5 days. So remember what I said about diagnostics. They're not as readily available as they need to be. We don't have any of the logistics set up for this well at this point. So it's critical that when you wake up and you think you might have COVID, that you quickly are able to get tested, and that if that test is negative and it's a rapid test, we know there are false negatives, so you're going to have to repeat it in 24 hours and maybe repeat it again. We're going to have to make sure that you can contact your healthcare providers in a reasonable amount of time, and your healthcare provider is going to respond. So the devil is going to be in the details, but this drug works really well.
Well, thank you so much for that answer. We're going to be just still moving in this time. Thank you so much. We have quite a few questions in the chat on our Facebook viewers and our YouTube viewers, and we're not going to be able to get to all of them right this moment. Maybe if we have an opportunity at the end to add some more questions, we're having our speakers speak and do a little question and answer. We're going to be moving to our next speaker and have some Q&A at that time. And if we have enough time, we'll come back to some of the questions that are being posed at this time after Dr. John Swartzberg's presentation. But now we're going to hear from another professional here in the community as well, Dr. Kim Rhodes. She is an associate professor of epidemiology and biostatistics at UCSF School of Medicine. She has a formal training as a general and colorectal surgeon. She has additional training in basic science, healthcare disparities, and health policy research. She also trained as a community organizer at the Center for Third World Organizing during medical school. In her current role, she serves as the Associate Director of Community Engagement at the UCSF Cancer Center and as the Director of Umoja Health, a community-run COVID-19 testing and vaccination initiative where all the services are provided to the community partners in Oakland. Dr. Rhodes earned her medical degree at UCSF, a Master's of Health Science at UC Berkeley, and a Master's in Public Health at Harvard. Welcome, Dr. Kim Rhodes.
Thank you, and thank you for having me. And similar to Dr. Swartzberg's opening remarks about being honored to be on a panel together, what he didn't say is he actually was assigned to me as my medical school mentor. So it's really exciting to have the opportunity to speak in the same forum. I'm going to focus a little bit. We got a lot of great information about the science of COVID. I'm going to talk a little more about the social and, dare I say, political aspects of COVID and how that has translated into the experience of African-American folks here in the Bay Area and really across the country with COVID. Okay, hopefully you can see my slides and somebody will signal me if you can't. So I just want to start with some data from Alameda County. And I want to make a really important point, which is that although we talked a lot at the beginning of the pandemic about the pandemic in Black and Brown communities, as if high rates of infection was sort of an equal comment to make for both Black and Brown communities, it turns out it really wasn't. So if you look at the total case rates per 100,000 Alameda County residents, what you can see is that in the Latino and Pacific Islander community, that the rates were and have been particularly high. But when you're looking at the experience of African-American folks, we're actually fourth in terms of the number of infections. So we're not at the top of the list of those getting infected. However, when you look at mortality, we are at the top. So things sort of reverse. Some of the communities like the Latino community who were documented to have really high infection rates actually didn't have as high of mortality rates per population as the African-American community. I think this is a really important point because it means that the narratives are a little bit different, and it also means that the approaches to mitigation of harms may need to be adjusted. But either way, the reality is that disparities are just the tip of the iceberg when it comes to anything in healthcare. And the things that float the disparities to the top are inequities that are based on policies and practices that keep specific populations either in low wage or essential work type jobs with limited access to paid time off, limited neighborhood resources, and potentially crowded living situations. And these are the things that translated into high rates of infection. And we haven't really, I don't think, dug deeply enough into why the rates of mortality are so high in specific populations. But what you could see is that in the pandemic, when people were sort of unaware of disparities in healthcare and health outcomes, which were quite old, COVID-19 made people aware of the fact that there's a differential distribution of disease across racial and ethnic groups, as well as socioeconomic class. And in COVID-19, there were some specific aspects of it that drove some parts of the pandemic. In the beginning, you may remember we had limited access to testing. We then had differential access to vaccination. I'll talk about that a little bit later. But the initial recommendation for mitigation was to shelter in place, which meant work from home. Well, some jobs can't be worked from home, and those jobs disproportionately were held by people of color. And then when we needed hand sanitizer and personal protective equipment, it was difficult to get. And now when we're thinking about schools and mitigation, we also need to think about how run down are the schools where Black and Brown students are clustered. Do the windows open or have they been painted shut? Does the water run to wash hands or do only certain sinks work well? So all of these sort of structural issues contribute to some limitations in the ability to undertake the measures required for COVID-19 mitigation. I think the first study that really at the beginning of the pandemic that really exposed the social distribution of COVID was the Unidos en Salud study, and that means United in Health, and that theme is gonna keep playing out. This was a UCSF initiative that focused on testing in 2 specific mission district census tracts. And this was at a time when testing was nearly impossible to get unless you had 3 specific symptoms, had been exposed to someone who had a documented test, or were a healthcare worker. So it was nearly impossible to get a test. And what Diane Havler at UCSF did was open it up in the mission district and make it absolutely no barrier testing. Now, I shouldn't say absolutely because this was a study. So they limited it to 2 particular census tracts. They went door to door and they got people out to come and get tested. And what they found really was the social distribution of COVID. And in fact, what was most notable was that for those who tested positive, the majority could not work from home. And further, that the folks who did test positive earned low wages and lived in households that were somewhat overcrowded, typically multi-generational households. But really significantly was that of those who were positive, the large majority were Latino, and of the white participants who tested, they all tested negative. And I think this was shocking for everyone, particularly in the university. We live in this neighborhood in terms of our where our buildings are, where we work, where our hospitals are. And so there was a desire on the part of the chancellor to repeat this study in Bayview Hunters Point. Bayview Hunters Point has a large concentration of African-American people, as does the southeast sector of San Francisco. So we took a similar approach by partnering with a number of different organizations who were already working on the ground to keep their communities safe in District 10. And mind you, this was April 2020. So this is very early on in the pandemic. And what we were able to do is set up 4 days of testing where we were able to engage over 2,000 folks. Our goal was to look at census tracts where we knew there were high rates of infection already. And those census tracts are shown here. What you'll notice is that the average between the 2 tracts of 53% Black and African-American residents in the 231.02 tract and then 23% Black and African American in the tract that represents the Sunnydale neighborhood. We should have expected to get about 38% African American participants at our event. And we went one step further and made the testing absolutely no barrier. So if you showed up, we would test you. It really didn't matter who you were, which neighborhood you were from. That was slightly different from what they did in Unidos en Salud, where if you were not in that census tract, they really wouldn't test you. So we did it less like a study and called it more of an initiative, and started to shift the narrative from the academic desire to document and study specimens who are outside of us and different from us, and more of a service orientation to figure out what we could learn about how folks were willing to engage with testing or what they felt about COVID. And what we found, we were slightly disappointed because for the African-American community, we only got 29% African-American participants, which is of interest because what you see here is that 17% of the participants were white, when the average of white participants in those two census tracts should have only been about 4%. So this is clearly overrepresented for white participants and very underrepresented for African-American participants. Now, you might ask yourself, why? And I'm going to take us on a short sidebar about the history of untrustworthy behaviors by institutions. In a lot of our mobilization efforts, we were hearing things like, you might give me COVID. I don't know what's on that Q-tip that you're putting in my nose. And this was early in the pandemic when the sampling was slightly deeper than it is now. And so people were not very enthusiastic about the prospect of participating, and it's based on historical reasons. So I really recommend, if you haven't read this book by Toni Morrison called The Origin of Others, I really feel like it captures and encapsulates my profession's contribution to the otherization of Black and African-American people. I just want to read one passage that was published. These were ideas and concepts that were published in a peer-reviewed literature. So when we invoke the peer-reviewed literature as if it really is the end-all be-all, I just want to remind people where the peer-reviewed literature was so long ago, and just remind us that it really is the structural issues in our society that determine who gets to be a peer reviewer and therefore what gets published. So Toni Morrison writes that slavery required otherization, and the concept that forced exercise, which was so beneficial to the Negro, is expended in cultivating cotton, sugar, rice, and tobacco, which but for his labor would go uncultivated and their products would be lost to the world. So both parties are benefited, the Negro as well as his master. So there's a way in which slavery was justified on the basis of it was good for someone's health. It was good for the slave's health to get out and exercise. And then I just want to, just one other short passage from a report on the diseases and physical peculiarities of the Negro race from 1851. Again, peer-reviewed topic matter. The authors write, Negroes can only have their intellectual faculties awakened to a sufficient degree to receive moral culture when under the compulsory authority of the white man. So this is in the history of our relationship with healthcare institutions. And I mean, of course, we can't forget the Tuskegee Experiment, which I think is important because it colors people's opinion, although they may not know exactly what happened here, right? This is where treatment was withheld, but people have the perception that syphilis was given to the participants. So this still lingers in the background, and we definitely heard about that as we were trying to mobilize people for testing in Bayview Hunters Point. And then should you believe that this is all ended and everything's all healed up, I just want to just flash across the screen some peer-reviewed work that actually does point to differences in the quality of care. So this study in 2006 is one of my favorites. Videos of Black and white participants, actors telling their clinical histories to cardiologists, and then getting different treatment, even though the stories were exactly the same. The risk factors, the comorbidities, nothing was different between them. The only thing that was different was the color of their skin, and nonetheless, in a simulated study, cardiologists chose not to give African American women invasive procedures in a disparate way. And then we know that complaining of chest pain while Black, this is the joke that Dr. Lenny Lopez, who wrote this paper, and I call his paper, where Black and Latino people were less often provided an aspirin, triaged as emergencies, given an EKG, some basic cardiac interventions when they reported to the emergency room with chest pain. And then I've written several papers about disparate treatment for different kinds of cancers in California, and really showed that some of the disparities gaps can be explained by these differences. So this is not old or over, it's right here with us. And it in fact then colors the way folks interact with healthcare or perceive public health to be caring for their well-being. And that influences how people access care. So what we know based on, having this history is that we need to shift the narrative through partnership and different kinds of partnership. So after we did our big mass testing in Bayview and didn't really reach as many African-American folks as we wanted to, what we didn't anticipate was that the partners that we had worked with and toiled together for months to pop up this massive testing activity called us 3 weeks later and said, you know what, we know there's going to be an outbreak because we know there's someone who's positive. We've learned a lot about COVID. We understand exponential spread now, and they learned it through participating in delivering services. They said, can you please come back and do more testing, which was almost unheard of because, right, we had just gone through, I don't know if you're poisoning me, I'm not sure what you're doing here, and I don't think you care about me, to the partners actually reaching out and saying, I think we learned that maybe this group, United in Health, cares, and so we want to have you back. This was the first pop-up testing and any pop-up COVID services in the Bay Area was in June of 2020. And we tested about 118 people. We popped up right on the street in Sunnydale. And at that time, we noticed a huge difference. Instead of the 23% of African-American folks who live in Sunnydale being represented in our testing, it was actually 63%. And that was because we could see, and you can see by the quote here from Vincent Fuqua from San Francisco DPH, that it was amazing how the neighborhood came together. People were happy to get tested and were texting friends and family members to get tested too. In fact, we saw influential family members in the neighborhood knocking on doors and asking people to come out because testing was available right there in the neighborhood. And in the process of doing this partnership, we actually were able to squash a small outbreak in the Sunnydale neighborhood and instituted weekly meetings in order to keep track of what was going on, what the community partners were observing on the ground, and then responding to that using resources taken from UCSF and San Francisco Department of Public Health. So there were many lessons learned from the United in Health District 10 initiative that informed what became Umoja Health in Alameda County and the ways that we've been taking action against COVID. We started by looking at data and by sharing data. So when we got called to come into Alameda County, what we looked at right away was, where are the infections? And what you could see is that these heat maps show you that the dark colors show you where there are high rates of infection. And again, remember, this was in the summer of 2020 at this point. And you could see that 94621, 94603, and to some extent 94605, and as well 601, which is Fruitvale, had high rates of infection. But the testing in the lower map, you could see was much lower in 94621, 94603, not commensurate with the rate of infection. 94601 had great testing because they were actually crossing zip codes to access Roots Clinic, which was providing low to no barrier testing. So we thought that we need to, number one, raise attention about the mismatch and actually try to engage with the public health department to get some accountability for that and to start intervening on what we could see was a discrepancy. So we started hosting a weekly meeting. And as you can see, this is our cover slide from February 2022. So we've been hosting a weekly meeting now for almost 2 years. We started off in our partnership with the Friends of Dr. Frank Staggers, which is a subcommittee of the Men's Health Committee, which is part of the Community Advisory Board of the Cancer Center at UCSF. Through the members of the Friends of Dr. Frank Staggers, which include Mr. Michael Shaw, Baba Arnold Perkins, Baba Gerald Green, we were connected to the Brotherhood of Elders Network. And some of you may know that they were hosting the African American Response Circle, coming together to try to figure out what to do about COVID. The first activity we undertook was July 4th of 2020 around the lake, passing out hand sanitizer, masks, trying to be very loud and boisterous in the parts of the lake where African American people were gathering about the dangers of COVID and trying to provide some information. The public health department was out there with us. And you can see over time that we have built up this large and broad coalition of stakeholders, including faith partners, as well as community-based organizations, academic institutions, public health departments, school districts, fire department. And everybody decided that we would work together, despite the fact that we had all never worked together before, to advance an agenda that centered the African American experience with COVID. One of the things that Baba Arnold Perkins, who some of you may know is a former director of the Alameda County Public Health Department, but also leads our Community Advisory Board in the Cancer Center at UCSF, says, "You can't teach what you don't know, and you can't lead where you won't go." And what that means is we've got to get outside of the building. And I think we learned that in San Francisco, and we brought that to Alameda County. So we asked a question: where are the African American people living, playing, worshiping? And those are the places that we're going to go. So we asked the Department of Public Health to give us a map to show us the distribution of African American people across Oakland and Alameda County. The reality is we had started off trying to focus on Deep East Oakland, but we realized in the process that if we did, we would miss all of the folks in West Oakland who are having similar outcomes and experiences with COVID. So we decided to ask our partners, where do we need to be? And they said one of the places is with the Black Cultural Zone at Liberation Park. So we did our first pop-up on September 6th on the same day that Acoma Market opened. And before every pop-up after that, and these green dots show you where we ended up popping up. These were all recommendations based on what our partners had to say. But we would canvass the neighborhood, send folks out in our emoji t-shirts, and having them pass out flyers that were deliberately designed with Afrocentric colors to really communicate that this is the community trying to save the community, answering questions about COVID, and directing folks to come by the pop-up, whether they wanted to be tested or they just wanted to get information. So as I mentioned, and you may see some people who look familiar to you, Pastor Brandon Reams came and got tested. At the time we were checking antibodies. We no longer do that. Reverend Cheryl Ward was there. And we basically set up a COVID testing site just on the outside, effectively on the corner of 73rd and Foothill. And this was the beginning of the pop-up craze in Alameda County, which started again in September of 2020. What you can see here, when we started asking the question about what proportion of our services are reaching the African American community, and this was an important question because, as I had mentioned, Roots was available to our community because they have been serving the African American community since their inception. 85% of their patients are African American, but nonetheless, when you look at who was coming for COVID testing, you could see that the numbers were quite low. So we compared ourselves to brick and mortar, Roots Clinic and West Oakland Health Council over this short time period. And you could see that sometimes we doubled or tripled our service to African American community compared to the brick and mortar. The brick and mortar expects for people to come to them. We were saying we're going to bring it out to the community. And you can see that it makes a significant difference in how we're able to reach African American people. Overall, for that 2 months of testing that turned from a mass testing for events into a every weekend pop-up situation, we provided 55% of our services to the African American community. We had a huge number of first-time testers, and the majority of them were African American. Interestingly, when we came back after January of 2021, or excuse me, in January of 2021, the bulk of the testers who were African-American were no longer first-time testers. We know from the county that during that fall of 2020, African-American people became the highest rate of testers across the county. And we think this had something to do with opening up the dialogue and hosting that community meeting where people could feel like they were getting access to information as well as having the opportunity to volunteer, so they felt that they could really be involved in the process. When we asked people if they were willing to be contacted for future research, what we saw was that the large majority of those who said yes were African-American, which shocked everyone. We didn't have a study that we wanted to invite people to, but we were just curious. And we think this was a testament to the way that we were delivering services. And then we also asked, because this was pre-vaccine, if people were open to the vaccine when it was available. And what you can see is that African-American people had the lowest rate of openness to the vaccine, but when we compared that to the national rates, we actually were exceeding the 38% that was reported in the Pew polls. So based on that, Alameda County decided to give us our own vaccine allocation once the vaccine was available, because they could see that what we understood is that this lack of trust is an expected response to historically untrustworthy behavior. And there was a way in which we were flipping that whole thing on its ear by making sure that it was community serving community. And so there's the lack of trust that we sort of point to people like, what's wrong with you that you don't trust? We really said that we understand that that's not, the lack of trust is completely justified. So it is not a negative, it is actually quite rational. So we started trying to focus on how we could tailor our messaging around the vaccine and how we could continue to deliver the services that we deliver in a way that centers African-American people. Of course, we were thwarted by, I would call them structural forces. So the initial vaccine rollout was aimed at those residents in our state and in the country who are over 65 years of age. And what you could see here is that in Alameda County, the bulk of our residents are actually under 65 years of age. Furthermore, when we looked at deaths, which the vaccine is intended to reduce, and not so much infection, which is another, I think, messaging problem, right? We were kind of given the impression that it would reduce infections, which it does, but we still saw people getting infected. But the reality is the vaccine's endpoints when it was tested in trials was to reduce severe COVID hospitalizations and death. So when you ask yourself, if you want to prevent deaths in the Black and Latino community, what age group should be getting the vaccine? And so this little inset is showing you here that the majority of deaths in the Black and Latino community at the time the vaccine was rolled out were in those under 65. But nonetheless, the vaccine was recommended for those over 65, which serves populations who tend to have better access to care and a different kind of relationship with care processes. Furthermore, in the beginning, you may recall when vaccine was in short supply and we really didn't want to throw any out and couldn't afford to, the California Department of Public Health sent out this letter to all vaccine providers, letting them know that they're going to be managing and improving future orders based on, quote, shots in arms, which is a kind of language that really doesn't center the experience of African-American people at all. But really what they're saying is that given the scarcity, they want to minimize the volume of vaccine that just sits in freezers, and we're going to closely monitor the doses. And then we're going to start shifting incremental future doses to high throughput sites, so the mass vaccination sites. And we knew right away that those mass vaccination sites were not going to serve our communities. So we actually got our youth mobilizers sitting out in front of the Coliseum, sitting at the BART bus bridge. And what they did was they counted, and this is really guerrilla research, so this is not going to be peer reviewed, but this is folks looking for, do I see African-American or Black folks coming out of the Coliseum? So we counted cars coming out of the Coliseum. We counted folks getting off the BART and getting onto the bus bridge. We documented that these buses taking people across the into the Coliseum were empty. and very rarely carried a Black person on them. I just want to point out that most people who live locally near the Coliseum, where they put it there specifically to serve some of the zip codes with the highest infection rates, they walk across the footbridge into the Coliseum. They don't ride a bus. But the problem is when you walked across the footbridge, you actually couldn't get into the vaccination site. You would land yourself outside of the perimeter and you would not be let in. You had to come on the bus bridge. So this is clearly not set up for the local folk. Furthermore, when you're coming into the Coliseum, not off of the freeway where all the Teslas were coming in to the Coliseum to get their vaccines, but when you come in from 94605, it was actually blocked by a police barricade. This is not welcoming to the community that mass site was meant to serve. And so not surprisingly, what we saw was that the service to those sites did not do well. Now, in consultation with a number of community groups, many of whom were part of Umoja Health, FEMA asked whether or not what they thought about where they should partner for the mobile clinic sites, which are shown down here, and you can focus on Oakland. And we were there to say that, I'm sorry, 2 mobile buses is not enough. You're going to need to partner with more than 2 sites. So the great thing was that we were able to influence the increase in mobile clinics. And that was important because, as you can see here, when you compare the service to African-American folks in Oakland at the mass site, it was 4%. And I just want to give an applaud our youth mobilizers, because the percent of African-American folks that they counted in terms of counting cars and then what percent were African-American, they got 3.8%. So even though it was guerrilla research, it turned out to be pretty good. But what you could see is that the mobile clinics, which were partnered, I know Allen Temple had mobile clinic, True Vine Ministries had mobile clinic, that's where they captured this much larger and overrepresented percentage of African-American folks. So we come away from this understanding that trust builds at the pace of the relationship, and we hope that our institutions don't forget that. So when we ask the question, how can we build trust? I think we should step back and ask the question, what kind of relationship do we have? Because if there is no relationship, there should be no trust, and there should be no expectation of trust, given that there is no relationship. This also means that trust builds over time, in the same way that our relationships do. That's true with your friends, the people you know, the ups and downs you've been through together, and how you come out of that with a deeper sense of shared trust. Academic institutions and public health institutions really need to take this lesson to heart, because we're not in this relationship just because of COVID. Remember, I started telling you about this work that spawned out of our relationship with our community advisory board in cancer. They said we need to look at COVID, and we said, you're right, we need to look at COVID. So it's about building the relationship. It's not about some magical trust that's going to suddenly develop out of nowhere. So what we started really focusing on in terms of data, again, and getting our the partners who sit in on the Umoja meetings, is to help them understand about this concept of case fatality rate. And the case fatality rate is a statistic that roughly gives you a sense of an answer to the question, if I get COVID, if I get COVID, you know, what are the chances that I will pass away? And you can see right here that these data are the most recent data from Alameda County. And you can see that Black Alameda County residents still have the highest case fatality rate. So it's not really about who's getting infected. It's really about who's dying when we're talking about what we can do and what we can accomplish with vaccination. So we're again using data. It's the same data that is available to everyone, but we're using that data through an Afrocentric lens, or a lens that reflects on the experience of COVID in non-majority populations. So with our little vaccine allocation and our small but mighty volunteer network, we've been able to directly provide vaccination services. So we don't have a big organization behind us providing the vaccines. We are actually providing the vaccines ourselves. And so you can see that of the some 4,000 vaccines that we've provided in Alameda County, that the majority have gone to African-American participants. So if you look at mass vaccination opportunities, especially when the barriers are low, what you'll start to see is the percent of African-American folks drop off because other people show up when it's easy to get access. And I also want to just point out that 53% of our vaccinations have gone to our target zip code. So I think we're doing a pretty good job of listening to our partners, going where they ask us to go, allowing them to mobilize people to our sites because their relationship is what with their communities, with their neighbors. That's what we're relying on in terms of getting the work done. But I think bigger than the actual numbers is the impact of what we've been doing to influence folks to feel like they have a say and that they have the capacity to have an impact in this pandemic. And so now this model, because we're not an organization, we're a model of bringing communities together along with public health departments and academic institutions to hold institutions to account. And so the model is spreading. We are now in San Mateo, both North and South County, as well as in San Francisco. And the alliances are also continuing to expand. That was San Mateo. This is San Francisco. And what we count, as I said, more than the actual doses of vaccine that are administered or information that is shared, it's really about capacity building. So what you can see is that this number is quite low. There's probably closer to 60 organizations engaged with the Alameda County Umoja. So a lot of organizations together, some healthcare organizations who have never collaborated with each other before. Remember, this is about public health. So we need everybody in. It's not just your Kaiser covered lives. It's not just who's going to use UCSF or Sutter. It's about all in, everybody together. And the activities that we undertake look quite different. So in San Mateo, they are knocking on doors like crazy and talking to people and providing information. And in San Francisco and Alameda County, we're trying to provide direct services. But we also use the meetings as an opportunity to let folks know that funding is available and that we will provide a letter. And the benefit that we have is that that letter now comes on UCSF letterhead. So that provides a little lift, I think. We've been able to help folks secure over $3 million in contracts and grants to do work on COVID in their community on the ground. And then particularly important to me is the workforce diversity impact that we're having in our youth mobilizers and our summer interns and training youth leaders down in San Mateo. Just a glimpse of our youth mobilizers. So we had first started with a summer research student in 2021. We then took on and got a grant from Life Sciences Cares to support 5. 4 of them are first generation college, 4-year college matriculants. And they're all looking at healthcare or public health careers, and we're going to help them get there over the course of the next 3 years, supporting them through their academic pathway. And then we've got our Umoja Health Youth Mobilizers, which we're trying desperately to make sure they stay integrated in the public health department, because these are the voices that are missing. When we look at who's not getting vaccinated, it's 18 to 34-year-olds. They need to hear messages that are not coming from the public health department, but that are coming from young people who understand what young people care about and can craft the messages so that they are more relevant to those populations. Finally, I love this quote from Baba Arnold Perkins. I mean, it just motivates me every day, because after all is said and done, a lot more is said than done. We, in this endeavor, are taking action to meet people where they are, and it's always about action. We're cultivating relationships and trust actually by being visible physically in the community, not just talking about COVID, not just doing the informational sessions, but also showing up and answering the questions in person. We're hyper local. So the data that we provide is always relevant to the counties that we're talking about. And that means that the communities that we're serving also vary. In San Mateo County, you might note that the service is largely going to Latino and Pacific Islander communities who are suffering the burden of COVID as well. And the reason is because that's who's coming to the table. So again, this hyperlocal approach we think is the most effective in keeping people informed and preparing them to mitigate against COVID. And we do deep community engagement. So the folks who are on the ground mobilizing, the folks who are doing surveys on the site, the folks who are welcoming people on the site and doing the registration, they're all from the community, and they're all from the communities that we're trying to serve. And as I mentioned, we have the weekly meetings. I think one thing that's super important about that is the data that gets gathered the week before gets shared back that same week. We don't embargo or hold or hide the information. Want to be fully transparent. On our website, you can watch every meeting we've ever had. You can look at every slide deck that's ever been shown. Because what has traditionally happened is that this information has been hidden from the public. And that, again, does not engender trust. So we are about transparency, and we're also about giving the data back because it's the community that generated the data. And then the next question is, and what do we do about the data? If community is involved in generating and gathering and getting it shared back and understanding it, then community will be, I think, more deeply engaged in creating the solutions. So as I say, we don't just talk about the problem, we are an active part of the solution. And I'm not sure that folks would want to continue to be engaged with us. And I see this in our young folks. I see it in my office staff who are reluctant to go back to the way we were doing our cancer work because they feel like there's not enough action. We're not doing anything. We're doing a lot of talking. We're trying to write a lot of papers. And so Umoja is really about a new model of how we do public health and how we engage the public in participating in that process and being part of the solution. So I'm happy to take any questions. And I just want folks to know, if you want to get vaccinated, tested, or boosted, we are here for you. You can look on our website and see where we're going to be appearing. And if you have additional questions, you can email us at info@unitedinhealthoakland.org. Thank you.
Awesome. Thank you so very much, Dr. Kim Rhodes, for sharing with us a grassroots effort. Go back to passing out the flyers. Go back into the neighborhoods and knock on doors. And if not, that gotta be safe. So even if it's leaving them on the cars like we used to back in the day, we need to get back to that. Trusted voices is what helps in this. It will help very much in this area, I'm sure.
Can I point out one thing about that? So yes, COVID safety. And for those who work with me, people know I am probably one of the most COVID paranoid people in the world. And what I say now is we move toward this lifting of the mask mandate. I'm not taking my mask off. I think a few weeks ago when we were really big in the Omicron surge, one of my staff turned to me and she's like, Dr. Rhodes, you're wearing 3 masks. And it's like, yeah, actually, well, whoops. But what I say is I'm not trying to get COVID. And that's really the bottom line. But in terms of the early pandemic, when we're all isolated from each other and people were lonely, getting them to come out and having them learn how to set up the site. What does social distancing look like? You have a job that is to keep the line separated from each other, right? People then start incorporating that into how they live their lives and take it home. I used to have to say, please don't hug each other. I know we're really happy to be around people, but please don't hug. And now people really know that and they can transmit that farther than we can actually deliver that message directly.
Again, thank you so much. I'm so happy to hear about the work and things that Umoja Health is doing in the community. Let us know how we can help you, if there's anything we can do. Let's get to our questions. Let's see here. We have a question from Linda Mack. Will all the information today from both speakers be available to access, review again, and share with others? Yes, I believe so.
Absolutely.
Yes.
This is a recorded webinar, and so you will be able to see it on YouTube, Facebook, I believe as well. So it is available. And as far as any of the slides or anything, we'll touch bases with our presenters and confirm what they'll be able to share with us. Thank you so much for that question, Linda Mack. Anonymous attendee asked, I live in Contra Costa County and wish this was available to those of us in Richmond, San Pablo, Antioch, Pittsburgh. Any thoughts of coming into our area?
Yeah, that's a question that keeps coming up even amongst our participants, because even though we were working initially in Bayview, we were getting a lot of testers from Oakland. We call it the Black diaspora across the Bay Area. People may live or have an address in one place, but stay in another place. And that means that we're all connected. So we do need to be in Contra Costa, in specific parts of Contra Costa, right? It's like 3 different counties. But Richmond in particular, and Antioch, I think, are places where we would love to focus, but what's required to have an Umoja Health forum are broad partnerships and a public health department that's willing to come to the table. Because we can all talk to each other until we're blue in the face, but if we don't have the folks holding the controls of accountability, things may not change. So if we didn't have Alameda County present at our table, we wouldn't have been able to get vaccine. If we didn't have a San Francisco DPH at our table, our ability to pass out at-home testing kits on the street would not have happened. So that policy change and that structural impact requires that we have the public health or in health institutional leaders to come to the table and bring their resources.
So much. Question from Dorothy Guillory. Why is the Bay Area doing better than the rest of California in handling the COVID crisis?
Yeah, I think that has a lot to do with the Bay Area public health departments being willing to engage with community in ways that other parts of California may not be engaged. It is, I think, notable and significant. I started with the United in Health model. That model has been kind of the central, the bedrock of these community engagements that have been going on in other places. And I want to point out that Umoja means unity. And that is the name that the community picked for the United in Health initiative in Deep East Oakland. In Fruitvale, it was called Sanando Juntos. And as I mentioned, it's Unidos en Salud. And then in Bayview is United in Health District 10. In San Mateo, it's just called Umoja Health San Mateo, because they took up this idea of we all just actually need to be working together with a singular focus, and didn't take on another name, because they understand it really is the concept. And the Bay Area has embraced that. So I did at the beginning of the pandemic, with the leftover money I had in my Office of Community Engagement for Cancer, I said, you know what, we're not going to use this money because people aren't going to come together and eat. So we're going to just put this money out into the community and fund what we're calling COVID Emergency Communications Grantees Network, to build the capacity of our community partners to communicate in a pandemic. And just recently, with the lifting of the mask mandate, a number of these organizations were distressed and are distressed about what is the plan. The messaging has been bad. We just last week got told to upgrade our mask to a KN95. Now we're being told it's okay if you take your mask off. The messaging has been like whiplash. So we reached out as a network to BARHI, which is the Bay Area Regional Health Inequities Initiative, to say we want public health officers to come to our quarterly meeting and talk to us about how you're either coordinating or not coordinating your messaging. And they responded. And they responded, I think, because they know that we're able to gather a lot of people together, a lot of constituents where they can reach them directly. So I think the Bay Area has done well because the public health departments are willing to engage with communities, and because we've been able to build strong community coalitions. Again, I think really starting with Diane Havler's work in Unidos en Salud, with this concept of bringing community together to speak truth to power.
So much. We do need this all over the Bay Area for sure. Let's see if I have another question. I know Dr. Swartzberg, we wanted to get you into joining us again on screen, if you don't mind. See if we have anything else out there before we have our Deacon Harold Goodman come on. Let's see if I'm missing anything. I know there were some questions before earlier that we may have missed. We're going to have an opportunity to, if we are not able to get to the questions, and it looks like we may be very close. This is a hot topic. We have a lot to talk about this, and we might need to have, I don't know, I'm not going to put a put a thing up there, maybe part 2, not sure. But there'll be some questions I think that may have been missed earlier. We will, if it's okay with the 2 of you, any that come up, we can provide them to you and maybe can provide support responses, maybe via writing an email. We'll coordinate what that might look like. But at this time, looks like we are at the time to bring on our chair, our leader for the Health and Education Ministry, Deacon Harold Goodman.
Thank you, Sister Rika. I just want to say thank you to both Dr. Rhodes and Dr. Swartzberg. This was just very informative. I think we've got a lot of good information, and I know our congregation and our visitors will be sharing. So once again, we just say thank you, and we just thank God that you were willing to take your valuable time to share with us. I'd also like to ask that as we come after the prayer, there's a brief survey. Please stay on and complete the survey, because we ask questions on the top of topics, that you would like to hear in the future. So please do that, and thank you very much.
Okay, and so, looking at our time, looks like, I don't know, tell me what you'd like to do, everyone. We have a few more minutes. So I think it would be great for us to see if I can check again and see if there's any other questions. There might be some conversation that you can have together to help us in this. If you have something else you want to share, I think a hand up. I see Dr. Rhodes has a hand up. We're gonna let her have some time. And Dr. Swartzberg, if you'd like to jump in, all right. And so I'll call, and I'm gonna I can't ring a bell, but I'm gonna say something, give you a little, we got a few, then we're almost at our time for closing prayer, okay? Go ahead, Dr. Rhodes.
This is actually a question for Dr. Swartzberg. So a number of Black doctors are coming together because we do think that we need to make a statement about the messaging and who's at risk. That's why I brought up the case fatality rate, because if we kind of let fly and say, well, COVID's here and whoever gets infected doesn't matter, we know who's going to die. So we're concerned. And one of we're trying to come up with strategies that really center the epidemiologic experience of Black people. And one of the questions that we had was whether or not there is anything in the works to measure levels of immunity, neutralizing antibody, so that do I need another booster now, or am I okay? And do you know if anybody's working on that? Because I think that will be quite useful in our community where there have been infections, and so people have some level or some degree of immunity that potentially could be checked in order to have a I don't know, more scientific feeling of safety.
Yeah, that's really, I would say, one of the top and most important questions in this pandemic in terms of from the science standpoint. What Dr. Rhodes is really asking is there a way to, for example, with a simple blood test, to answer the question, am I immune to the virus? Do I have good protection against it? That would take away so many questions about, do you need a 4th jab? When do you need a 4th jab? And so on. So it's a critical piece of information. And there are a lot of people working on this. The closest we are at, I'll try not to be arcane in my answer, but the closest we are at in terms of an answer is that I think we're honing in on the level of neutralizing antibodies, a certain titer, a certain level that will correlate with protection. And I suspect that within the next several months, we will have that. Once we have that, it's going to really make a big difference in so many ways. Actually, I wanted to comment on one of your comments, Dr. Rhodes, just to really dilate on one of the things you were saying about the Contra Costa community. Since almost the beginning of the pandemic, I've been working with a group of African-American churches in Richmond. And it's been really so gratifying to see that the work that they've been able to do with the African-American community in Richmond through the churches, tremendous success. One just quick example was that in the spring of 2020 and in the early summer of 2020, there was one site in the entire city of Richmond for testing. At the same time, there were 11 sites in the city of Walnut Creek, also in Contra Costa County. This group, led by 2 or 3 just fabulous folks, got the county involved. And by the way, one of the senior health officers in that county is someone you know, your classmate of yours, I think. And they have been very responsive and have done a good job working hand in glove with the Richmond African American churches to not only improve, get more testing sites, but also get more vaccination sites and bringing in mobile clinics and so on. So it's the kind of work you're doing, Kim, is so critical and makes a profound difference.
My guess is that some of those congregations have health ministries that have been supported by my office around cancer, because a lot of them transitioned to focusing on COVID, and then have a structure for, for how to sort of incorporate messages into services, create policies, and engage with, some of the academic expertise, as well as the resources that we provide to kind of keep those health ministries going. We like to, that makes me want to put in a plug for the Abundant Life Health Ministries Network at UCSF, which is, I think, 15 years old. It was started by Dr. Frank Staggers. I believe Allen Temple is a member, but we do have our annual gathering, the Great Gathering, in September. This coming September will be the 15th year. I'm sure it will focus on COVID because of all of the activity in the various congregations. It's largely been African American. It's now extending into the Pacific Islander church networks in the Bay Area. So wanted to put in a plug for that. And yeah, I should reach out to Ori and see if he's willing to start to, co-host some kind of informational session that happens on a weekly basis, because I think that's really where we're making a difference, is reviewing the data, asking what does the data mean, and then kind of making recommendations about what does that mean about how you should conduct yourself as the mask mandate comes off. And then lastly, we did, as an Emoja network in 3 counties, write a letter to Tomas Aragon, the head of California DPH, and we will be meeting with him to figure out how will California resource the community organizations on the ground who are still going to need to pass out home kits, need access to PPE, and potentially need to be starting to pay these volunteers who have been giving their blood, sweat, and tears for free to maintain good control over COVID in the Bay Area. So we did write a letter. If you wanted to sign on to the letter, please let me know. I think the more signatures we have, the more they understand that we really are serious about protecting our communities.
We have about 2 more minutes or so, and I did want to slip in a question. It seems like it came up a few times, but it was asked, if either one of you can answer, you both can. It was asked, why are some people reacting to the vaccines with stronger side effects than others? Sarah?
I don't know. I don't know. My wife, she gets a terrible reaction. She's had a terrible reaction to all 3, not terrible, but she really gets out of commission for at least 48 hours. And I have a real sore arm and feel punk for maybe 24 at the most. I have no idea. The good news is that a lot of people think if they don't get much of a reaction, they don't get much immunity, and that's just not the case. You're just lucky you're not getting much of a reaction, but you do get a good immune response.
And I think that's part of, the portfolio of what I feel like we don't know about the virus. So I'm not sure why we're in such a rush to, quote, get back to normal. Normal is how we got into the problems that we're in right now. But we don't know who's going to get super sick from COVID. We do know comorbidities matter. We do know age matters. But for the people who are young and healthy, we don't really understand why they have gotten so sick. And I think that probably relates to similarly to how we don't understand who's going to have severe reaction to the vaccine, which really is your own immune system, right? Doing work that you are now feeling. But I think I want people to kind of put this in the context of HIV, right? It's a similar kind of virus. We're 40 years with HIV. We don't really have a great vaccine. We just cured the 3rd person last week, right? So we need to temper our expectations. What it took to get to where we are with HIV is really understanding the virus really well. And I don't think we really understand this virus well enough to be able to make predictions about how people respond. And similarly, I think that reflects on responses to vaccine in terms of side effects.
Thank you so much for those answers to the questions so far. We have so many questions. This is, again, such an important topic, and we appreciate both of you again for coming and providing the science to us, the grassroots efforts that are going on in the community. But now it's time for us to wind down and say goodbye to the next time. We're going to have our closing prayer by Reverend Ronald Cole. He's the father of 5 children and 6 grandsons and 2 great-granddaughters. He's retired from the Social Security Administration after 20 years and now serves as a spiritual care counselor for the ACE Home Health and Hospice Company, which brings him much fulfillment. And with that, we'll have Reverend Ronald Cole give us our closing prayer. All right, Reverend Ronald Cole. All right, we're going to have.
If
I was still
are
on
you
mute.
there? All right,
I
Reverend.
was still on mute. I'm sorry. All right, let's prepare our hearts and minds for prayer. Father, we come to you as humbly as we know how, thanking you for your presence and the breath of life. We thank you for Sister Rika Wright for facilitating this event, and for our presenters, Dr. Swartzberg and Dr. Rhodes. May those that attended this webinar share this information, and may the information they share have a positive impact on our community. Let your will be done. We pray for those that have been impacted by COVID and ask that they be comforted and healed. We pray that the impact of COVID be lessened and the world be allowed to experience life as normally as possible. We know that your thoughts and ways are higher than our thoughts and ways, so we pray for understanding and wisdom as we go forward. All this we pray in your loving Son, Jesus' name. Amen.
Amen.
Thank you, everybody. Goodbye.